right, well, thanks everybody, and thank you for joining on short notice. I'm going to apologize up front because I have put these slides together also at relatively short notice, but I felt like we needed to meet as soon as possible as a community in order to really talk about what's going on and some options moving forward and just some overall thoughts. So I'm going to do my best to present both facts as well as some opinions for you. So I will do my best also to tell you what's real and what I'm hypothesizing. But I'm Julie Kanter. I'm the president of the National Alliance of Sickle Cell Centers, and I'm joined by Louis Su, who's our chief medical officer of the Sickle Cell Disease Association of America. We, of course, wear many other hats, but those are the two that we're speaking from today. These are our disclosures.
Julie, sorry, you'll need to share your slides one more time. It's not sharing right now.
Oh, bummer. All right.
Yep.
All right, so these are our entrants and our disclosures. So obviously we have an issue. That's why we're here today. I'm going to try and tell you a little bit more of what we do know, what we don't know, but where I think the questions are. Some recommendations that we have put together for individuals with sickle cell disease who are currently taking Voxeletor and Oxbryta. And I think what we're going to need to do as a community is see what we've learned, how we're going to apply this for the future. Because I do think long-term, this is going to make sickle cell stronger. This is going to make us better. And we're going to long-term, I hope, have better options for more individuals. So as most people know, but just to make sure everybody knows why we're here, on Wednesday, the drug maker Pfizer said it was going to withdraw Oxbryta from all markets where it's approved. And it really cited risks of painful complications and deaths. And they notified regulatory authorities, but it's important to note that this is not an FDA decision. This was a Pfizer decision to voluntarily withdraw Oxbryta from the market, discontinue distribution, clinical studies, and that includes removing compassionate use from the market. Specifically, some quotes that I pulled for today, the registration trial itself, the original HOPE trial, did not show this imbalance. And I want to explain why I think that's true and how we're going to have to explore these data and other data so that we can better understand what occurred and how we can move forward in a stronger pathway. So to review the two studies that led to this initial review and now withdrawal, the HOPE Kids 2 study is a randomized double-blind placebo-controlled study in multiple countries. The objective was to evaluate the effect of Oxbryta or Voxeletor on the sickle stroke screen, or TCD. And much of this study was enrolled in sub-Saharan Africa. And the goal was to see if this medication could reduce velocities in blood flow in the brain. And the idea is that if you can do that, perhaps you can decrease stroke rate. Unfortunately, there was a report of 8 deaths in the treatment arm, while there were only 2 in the placebo arm. And all of these had occurred within sub-Saharan Africa. And it seemed in some ways tied to infections, is that 3 people died from malaria and 2 from sepsis. Simultaneously, another study, GBT 440-042, was trying to assess Voxeletor in leg ulcers. In this study, there were 88 patients enrolled. They were older than 12, and they were in Brazil, Kenya, and Nigeria. And they also saw an imbalance of deaths, with 8 deaths in the open label part of this study. Open label means we know for sure that those individuals were taking Voxeletor and not placebo. And at this point, at the same time as these studies were halted, the European Medical Agency, like our equivalent of the FDA, initiated a review, starting really in July. And so what has happened since then? Well, as you can imagine, Pfizer said we need to review everything. We need to see all of the data that's readily available. We need to know what other safety events might have been reported, not just from the studies, but United States as well as worldwide. And when they reviewed this, we haven't seen these results, but what we know is that they continue to see a concern that the risks of this medication were outweighing the benefits. This is important medical companies, pharmaceutical companies like Pfizer don't make decisions like this lightly. And so we have to all recognize that they have done this to protect people with sickle cell disease. So what is Oxbryta or Voxeletor? I'm pretty sure all of you know this. It works by increasing hemoglobin's affinity for oxygen. So it makes the hemoglobin, sickle hemoglobin specifically, hold oxygen tighter. That prevents the polymerization that changes the shape of the red blood cell. So it, in fact, inhibits sickling. Now, different people respond differently, and some people, about 10% of their hemoglobin is bound up. Some could be as much as 30%. And that does prevent the red cell from sickling, but it may prevent that oxygen from being released. It's not clear. It was originally approved in 2019, and that was for children ages 12 and older, and then expanded in children greater than 4 in 2021, and was also approved, as you can see, by the EMA. So I wanted to point out something that I think is super important, and again, something that I want to consider in our conversations moving forward. The original HOPE trial that led to the approval had 274 people enrolled, 1,500 milligrams, 900 milligrams, or placebo. And people were randomized 1:1:1. What does that mean? That means a third of people were given the current treatment dose of 1,500 milligrams. Now, the original endpoint in this study was what we've all talked quite a lot about, this increase of hemoglobin from baseline of at least 1 gram per deciliter at week 24. Very importantly, the original protocol and study said that the endpoint had to also be a key secondary endpoint. What did that mean? Well, it meant they had to improve patient outcomes. And at this time, the drug was still under Global Blood Therapeutics. And GBT actually developed a brand new state-of-the-art patient-reported outcome measurement tool. I don't have this on the slide. And the long story short is they decided the tool was invalid. And so somehow that requirement for that key secondary endpoint was removed. So even though the FDA said it can't just be 1 gram of hemoglobin that's going to allow us to approve this drug, they then took that requirement away. So they no longer had to prove anything related to patient-reported outcomes, hemolysis, or incidence of vaso-occlusive crises. Now, we do know that this drug absolutely increases hemoglobin in most people and improves hemolysis. What we don't know, and what we still don't know, as I'm going to take you through a couple of these studies, is whether that led to any clinical changes. We saw some AEs and SAEs, and I reviewed all of these late into the night. Again, headache, diarrhea, and there were 4 deaths on this study, but they weren't attributed to the drug, and conditional approval was originally granted. HOPE Kids still followed this, looking at children. Now, in this initial HOPE Kids study, there were 147 children enrolled, but there are multiple parts of the study. I'm not going to go through all of those. I'm going to focus on the group C, in which the 4 to 11-year-olds were enrolled. What's important here is that only 45 children with sickle cell disease received the actual study drug that became approved for children. That is a very small amount of kids. And of those 45, only 27 kids completed that study. So we know that only 27 kids in this original HOPE Kids study actually received the drug at the dose for which it was approved. So there wasn't a huge amount of available safety data because there was only 27 kids. There were some interesting AEs, and some noticeable findings were that 10 patients of that original 45 discontinued early. Fever, vomiting, rash, diarrhea, similar to what we'd seen in other studies of Voxeletor, were the common adverse events, but notable pain in extremity was another very common one. Finally, the open label extension study was from the original HOPE trial to allow people who were receiving the drug to continue receiving it and to continue studying the drug. The primary endpoint remained the same endpoint as the original HOPE trial, so that 1 gram increase at 24 weeks. But then they looked at it at 72 weeks, so right, a much longer study, and they looked at hemolysis markers. Here, they again had several secondary endpoints, looking at pain crisis or vaso-occlusive crisis. They also measured patient functioning with what's called the clinical global impression of change. They looked at health-related quality of life, and they looked at an opioid diary. Again, the AEs and SAEs were similar to what we'd seen before, and we saw that there were some individuals who discontinued. And importantly, when you looked at who discontinued the drug in the open label, and this came from the original, you can see that more people taking Voxeletor actually stopped taking the medicine, discontinued the study. Again, this study did not show a change in annualized vaso-occlusive crises, but here we saw a little uptick in possibly a patient-reported outcome with improvement in this clinical global impression of change scale. There was no improvements in health-related quality of life. So I'm not going to read this whole slide to you because it's early and I don't want to put you back to sleep before you've had your coffee. But I think some things that the European Medical Agency brought to light are important. So when they reviewed everything about approving this drug, they had a couple of important points that I think are likely related to what we're going to talk about in the coming weeks. The first was an increase in vaso-occlusive crises. Now, it wasn't statistically significant in those individuals on the 1500 milligram compared to placebo after treatment discontinuation. So one place that's important. The next thing they recognized was this ongoing, long-standing debate, and if you've talked to me about this medication, I've definitely brought this up, this concern for tissue hypoxia. What that means is we know that hemoglobin's job is to hold oxygen and then bring it to the tissue. For a lot of reasons, it's very hard to measure the amount of oxygen that actually gets to the tissue. We're only really good at measuring the amount of oxygen in the red blood cell. So when we think about an oxygen saturation monitor, the O2 sat we're very used to, that measures the oxygen in the red cell, not the oxygen getting to the tissue. So they did bring up this concern, is it possible that if this oxygen is never released because it's bound by the Voxeletor hemoglobin, that there could be tissue hypoxia? And they did some exercise testing and they said it wasn't sufficient to note that. And then they also noted this could be a long-term risk of end organ hypoxia. And then finally, again, I think relevant to some of the questions everyone's asking, they noted some effects on the immune system. I'm not going to go through all of these, but I just wanted to point out that there were some concerns that weren't necessarily brought to light that were specifically about these concerns with the immune system and the effect of Voxeletor on the immune system. And I do see people's questions, and I promise we're going to get to them, so thank you. Other interesting reports, again, I went through every article I could find to really pull some interesting things that I thought were at least worth noting. One was a comparative pharmacovigilance study. What does that mean? Well, you may not know this, but it turns out that anytime you're taking any medicine, if there's a problem, you can actually report it. There's a system to report it. I would say we're probably not very good at doing it when we should because we're all busy people. But when they looked at this in this article, they said, well, what do we see when we look at hydroxyurea, L-glutamine, Voxeletor, and crizanlizumab? And what they saw were no differences really compared to the study. So there was nothing in this article that was reported. This is interesting, however. There was another study done that asked that exercise question that Europe brought up. And what they said was, if Voxeletor improves hemoglobin, it should improve exercise, right? That makes sense. Unfortunately, in this very small study, not a lot of patients, they actually saw in these 10 children with sickle cell anemia, it did not improve exercise capacity. And so that, again, sort of reinforces a concern that while this drug effectively binds oxygen and prevents sickling, it may not release its oxygen effectively. And then another study looked at people who had renal or liver problems who were taking the drug. And what they found was that it was okay in anybody who had bad kidneys, end-stage renal disease. It wasn't needing to be changed. but that wasn't true in the liver, and that you needed to dose reduce for patients who had significant liver impairment. These are some other actively recruiting studies that, of course, are being halted now. You can see the clinicaltrials.gov, the location, the title of the study, and we're not going to go through all of these, but wanted to show you the things that are being evaluated right now.
And for disclosure, I'm at Chicago as a sub-investigator with Withdrawal.
Thank you very much, Dr. Sue. Anything else you wanted to mention on these studies?
Nope.
Okay. I also wanted to bring up a couple of other interesting reports. Again, sorry, my slides are boring and they're not exciting. But I think, again, this is very relevant to this conversation. The first is an article that was hotly debated and discussed by Dr. Hebel, brilliant investigator, who had the same concerns, but he's much smarter than me, so he explains them in a much better way, that says, is it possible that this drug, when we shift that oxygen, when we say we're going to let hemoglobin hold oxygen more, might not release oxygen and could cause problems? And one thing I thought was most relevant in this is where this author said, silent disease is silent, and if not specifically sought, it will not be recognized. What does that mean? It means that we have to ask the right question or we won't get the right answers. So if we're not asking if this could result in more silent infarcts or could result in oxygen not getting where it needs to go, we don't figure out a way to ask that question, we might not be able to figure that out. And as we often see in sickle cell disease, it's also important to remember that absence of evidence is not the same thing as evidence of absence. Okay. The next is a very recent presentation that also echoes this same concern that was presented at EHA in a poster, the European Hematology Association meeting by Dr. Biedman this year, that looked at this same sort of question. Is this drug changing the way oxygen gets into the brain? That's really the question it's asking. It uses very fancy MRI technology to ask this question. And what it showed were that it may actually change or limit oxygen's ability to get in the brain. Now, it did see that it might improve markers of cardiac stress. So two very different things here, right? It may not be good for the brain, but maybe it's okay for our cardiovascular systems. And then this was an article that a lot of people have sent me in the last few days because I co-authored it. And it's very important for moving forward. This article was done by a colleague of mine and we specifically looked at a young lady who took this medication and did well, had an increase in hemoglobin with the medication, decrease in hemolysis. Unfortunately, when she went out of town on several different occasions, she would neglect to take the medicine. And this is really important because she would only miss the medicine for 2 days. And during both of these episodes that we reported in this article, she had a rapid breakdown of her hemoglobin. And a lot of people have asked, why is this? And that's because, as noted, the medicine causes the body to hold the hemoglobin to oxygen better, which means that people have more hemoglobin. So your baseline individual with sickle cell, whose hemoglobin might have been 7, now their hemoglobin might have been 9, 10, 11. So all this extra hemoglobin suddenly loses its stabilizing factor, meaning what makes it stay good and stable and not sickling suddenly goes away because the drug gets out of the system. When that happens, the hemoglobin can very rapidly break down. Now, this doesn't happen to everyone, which is why we don't see it all the time. But this experience with this individual allowed us to note some very important things. One, this was an expedited approval medication. And once it was allowed to be prescribed, anyone could prescribe it. You did not have to be a sickle cell specialist, an oncologist, or a hematologist. You could be any kind of doctor. 2, because it wasn't limited, it wasn't as well followed as it should have been. Meaning that if people didn't think they needed to check labs or follow individuals closely, it's possible that people got the medicine and then didn't see the doctor for a year. And this is hypothesizing. I don't know that. But even more concerning was that if you're taking this medicine and had to be admitted for a pain crisis, most hospitals don't keep this medicine in their pharmacies. It's too expensive. And so once you get in the hospital, you might have to stop the medicine. And that could cause a rapid breakdown in hemoglobin, pain, and other significant severe complications. And that is really important because what happens when you're in the hospital with a pain crisis and suddenly you get worse? A lot of doctors just say, well, it's just the pain crisis, right? Because they don't understand this could also be by not taking this medicine. And so this was something we wanted to draw attention to, and I think is important as we work on how we taper or stop giving this medicine. Okay, what do we not know?
Can I just mention?
Yes, go ahead.
But that is one case report, and
It is one case report.
right. And so not every single patient goes through the same thing.
Absolutely true. And we don't know who will go through it. And we know that for sure. It absolutely true. And so that's exactly what we're saying here. This is just a case report. So one person. And importantly, there's been a couple of other abstracts that did present similar. Dr. Desai out of Atrium Health presented one of those abstracts. But I will also tell you, we have lots of other people who've taken this medicine and not had that problem when they stopped it, forgot it, or ran out of it. So absolutely, as Dr. Su noted. We have some other abstracts. There's some anecdotal reports on people having more priapism with this medicine, but there's a lot we don't know. And that's really important. And that brings me to what I think is the most important, which is that everyone here I know, even though I can't see you right now because I'm in presentation mode, I know you all know that sickle cell is not a one-size-fits-all condition. And this is probably the most important item that we need to better understand, to help the FDA understand, and to really think about how we approach long-term. And everyone I take care of with sickle cell reminds me of this daily, right? This is me. I might be different than the person next to me. And so that really brings us to when a new medicine that has only ever been tested at the dose at which it's approved in 200 people. That's not a lot of people, guys. That means that we need to be very careful. I am all about new medicines, and I firmly believe that Voxeletor benefits some people a lot. I also firmly believe it causes harm, and that we don't know who it benefits yet and who it causes harm to, which is my guess at why Pfizer said we can't risk that harm and we have to stop it right now. But it doesn't mean we won't go back and figure that out. But it does mean that a sickle cell disease medicine should be given by a specialist with sickle cell disease. I've also seen many community doctors, because I take a lot of referrals from around the state and country, who started Oxbryta at the same time they maybe started crizanlizumab or started a new iron chelator. And you can't do that. You have to start a new therapy one at a time. And when this particular drug was approved, they had quite a number of what we call MSLs, scientific liaisons, people from pharma giving this medicine, giving advice on how to take it. And there was a lot of people in the community who perhaps don't consistently take care of people with sickle cell disease that started prescribing it. And so knowing it's not a one-size-fits-all condition, knowing that this requires a specialist to really look in case somebody has an adverse event that wasn't in the original trial, and knowing that that's not how this drug was dispersed and prescribed is important. What else? We've talked a lot about endpoints, and hemoglobin itself, all by itself, has never been a validated endpoint in sickle cell disease. So when they decided to use this 1 gram increase in hemoglobin, that's not proven to show that that's going to improve sickle cell overall. What was used to support that was historical data. There is lots of data that show if you have sickle cell and you have lower hemoglobin and more ongoing cell breakdown or hemolysis, if that is your baseline, we know that you're at increased risk for certain sickle cell complications, specifically strokes and pulmonary hypertension and leg ulcers and a few other problems. But we don't know that changing the hemoglobin will take care of that. And so we have used historical data in a way that it's not supposed to be used, because it's saying that we know low hemoglobin is not good, doesn't mean that we know that changing the hemoglobin will fix it. And we're not changing hemoglobin by giving blood here. Instead, we're changing the way hemoglobin works. And that might not be the best option. We also know that pain is very hard. It's very hard to measure pain, and we really need to think about how we define pain crisis. I agree with our sickle cell warriors. We need to leave the word crisis in what we're talking about. These are acute pain crises. But there are acute pain crises that involve true vaso-occlusion, and there are those that don't. And there's true pain crises that involve huge amounts of immunologic abnormalities, and those that don't. And so we need to keep that word crisis. We need to make sure people get pain medicine when they need it. And please know that I don't want to change that. And this is my opinion. This is not proven. But we need to do a better job of measuring a vaso-occlusive, or what I would consider an immunologic pain crisis. There's ways we can do that, and maybe that's a way we can move forward. That's my opinion. This is not data-driven. So what does that tell us before we start to open up in just a few minutes? We also know that there are a zillion and one people who really respond amazingly well to hydroxyurea, right? We still know hydroxyurea, hydroxycarbamine is our very best drug in sickle cell disease. And the only thing we know that works better if done appropriately are transfusions. But how many people have come to me and said hydroxyurea didn't work for me, or I couldn't tolerate those side effects? So we also know that different people are going to respond differently. And that in a rare disease where it's not a one-size-fits-all approach, we have to take that into account. We have seen the exact same thing with crizanlizumab. And in both crizanlizumab and Voxeletor, these studies, when they got approved, these drugs, we didn't see these bad outcomes. But the people who are in studies are more often the healthiest individuals. And when the drugs are then given more publicly, more widespread, they can be given to people who wouldn't have met those original criteria. And so we have to be very careful with new drugs because we know people are going to respond differently. And so we know, as I've mentioned, that there are people who feel so much better on Voxeletor. I have watched social media over the last 48 hours and seen people who are just aghast. How could this happen? How can Pfizer withdraw this drug when I'm doing better on this drug? These are questions that are important. These are questions we need to ask. But there are also people who've gotten worse. And I've seen sometimes where this wasn't noted, where they said, my doctor started this medicine, but I haven't seen them in 3 months, but I've been in the hospital 3 times. Or I've heard reports that are similar. And so, again, these were anecdotal reports. I know Pfizer is going to tell us these data. We're going to get to see it. But right now, everybody wanted to know, why didn't they tell us first? Well, it has to go through the FDA, and it has to go through legal channels. And so they're doing what they think is the safest thing. And while this is very upsetting to some people, we also want to applaud a pharmaceutical company who's taking our patients' safety first. What else do we know? We need better data. We know that we need what we call a clinical longitudinal data set. We need a registry. And I'm encouraging every individual provider, CBO leader, to encourage patients living with this disease, people who have sickle cell, to get enrolled on our registry. Because this is how we figure it out, guys. This is how we figure out which drugs work for which people. This is how cystic fibrosis is so far ahead of sickle cell disease. And we have to work together to do better. We also know that sickle cell specialists are important, and sickle cell centers are important. And yes, there are not enough specialists and enough centers, but that doesn't mean we don't try to create more, that we don't really hound our government, our representatives, our hospitals, and say, you need to make more room and more people to take care of sickle cell disease. This is where we advocate, because new medications like this need to be given by a sickle cell specialist. And we have to hold pharma and FDA accountable. These post-marketing registries, meaning after a drug is approved, have to be monitored, and you can't just monitor one drug at a time. If we're only looking at Voxeletor and not comparing it to people not on Voxeletor, if we're only looking at people who get gene therapy and not comparing that to people not getting gene therapy, we're not going to know the answers. So now what? Because that's a lot of the questions that I've gotten over the last 48 hours. So these are weaning recommendations that are not data proven. I'm going to tell you that right now. As Dr. Su said, some people have no problems when they stop the medicine. But if you have drug in hand, there's also no reason not to taper off or wean, because it might be safer and it's not going to be harmful to wean it. Or
And-
let me rephrase.
Right.
It may cause less harm.
Yep. And so our pharmacists have looked at this again with no data, but just said, yeah, from a basic pharmacist point of view, this is a way to do it. And if you have 1 week of medication left, then weaning over 2 weeks would be a way to drop it down 1 week at a step at a time. But it's completely without any data support. This is just a way to try not to cause harm and bring people down gently. I'm also suggesting that people pay extra attention to hydration during this time. And then if you're starting to have increased pain, increased symptoms, markedly increased jaundice, probably need to talk to sickle cell doc and get checked out. We should probably also collect as a community.
That's coming.
Make some kind of worksheet about
We have it.
reports we're getting. Yeah.
Yes, absolutely. Totally agree with you. And so this is our best recommendation with the limited amount of information that we have, which is what we know again about this drug is the way it works is by it raises your hemoglobin because it stabilizes it. A lot of people have heard me talk about sickle cell disease and use my analogy of a car. And I say this a lot because a car's job is to drop off its passengers, right? A red blood cell's job is to drop off its oxygen. And in this case, the seatbelt in the car is tighter. So of course it holds the passengers in better. And that allows for more people to get in the car safely. And it allows for more cars on the road. Let's just go with that. But when those seatbelts suddenly break and the cars crash, it's more likely that people are going to fall out. And that's what's going to happen if we don't be careful. So if you can, the best idea is to slowly lower that hemoglobin. And the way to do that, obviously, is not by removing blood, but slowly going down on the drug. And that frequent assessments, like Dr. Su said, if you notice more yellowing of the eyes, if people are having more pain or discomfort, these individuals need to be assessed right away. And that may be a time where someone needs to be transfused if they can get blood or given a little bit of hydration to help manage that. I also want to make sure, and this is, from the heart, I saw lots of people say, now what? Oh no, nobody's going to do what we need to do in sickle cell. This needs to just be a call for action. Keep the faith. There are so many new drugs being evaluated and trialed. But we really need to think about how we're going to study these, the endpoints that we use, and making sure there are enough specialists to give these medicines when they're approved. We need federal funding for sickle cell centers so we safely monitor and manage new therapies. As I mentioned, only 27 kids between ages 4 and 11 finished the study that led to the approved dose in children. So there may be a lot of things that we couldn't see in only 27 kids. And that may account for what we're seeing now. One way to do this is using data. So the National Alliance of Sickle Cell Centers has adopted a registry called GRANDAD. I didn't name it, but it's the Global Research Network for Data and Discovery. And this allows us not just to track people who are getting Voxeletor, but hydroxyurea, gene therapy, or people who aren't on any disease modifier. And it will help us know who did this drug work best for and why. And as Dr. Su mentioned, as a community, we're creating what we call a case report form, and we'll be getting this out hopefully by the end of today. It's a way to just clinically see what happens as we slow this drug down, as we stop it, get those data so that we have it, so that we have a way to share and better understand who this drug does and doesn't work for. Finally, last but not least, I have talked a lot about the consensus recommendations in sickle cell disease. Because just like we're seeing here, there's so many gaps in what we don't know. And we have to work together to answer these questions. We've developed some recommendations with a lot of people and a lot of smart people in the room and come up with some practice agreements that we can all do. These are listed on the sicklecellcenters.org website. We're going to continue to give these out to everyone and publish them as fast as we can. But we ask all our doctors treating people with sickle cell, nurse practitioners, physician assistants, providers, and community-based organizations to say, we should all be doing the same thing so we can measure what's happening, so we can better understand sickle cell and come up with the right drugs for the right people. And if we practice medicine that way, using harmony, we're actually going to understand which medicines work best for which people. And I know my patients with hydroxyurea who say, this doesn't work for me, want answers to that question too. This is about how we formed that. I'm not going to tell you that. What I am going to talk about is that we have what we call standards, things we think every provider with sickle cell needs to be doing to ensure good outcomes, and things that we recommend, often things that we would like to happen, but unfortunately, maybe we have funding that we need. My best example is I think everybody with sickle cell disease has the right to have an access to a psychologist and a social worker if they feel they would like to talk about what it is to live with sickle cell disease. And yet we are not federally funded to be able to offer that. Just an example of a recommendation. So I want to think about this also when we think about gene therapy. And I bring this up because you're like, why is Oxbryta related to gene therapy? Because right now we want to make sure that the people who know sickle cell best are who do gene therapy. Gene therapy is a lot bigger than one drug. It's about chemotherapy and high risk, but very high reward outcomes. But we don't want people who don't know sickle cell doing gene therapy. So I urge you to look at what the consensus recommendations say about who should do this therapy, how to involve your community-based organizations, how to work together to make sure that we're keeping our warriors safe. I'm going to stop there because I know we have lots of questions. I will be sharing these slides online, and there's a lot of references that I've put here in case you want more information. So Dr. Su, you want to start looking at the questions?
Yeah, I've been trying to type as fast as I can. And by the way, I'm willing to stick my neck out as personal recommendations. And so I wrote 1 or 2 personal recommendations. These are completely not based on any data. If you go to court, I'll go to court with you. But the idea of weaning for children who are not on pills, I think probably just have the same general idea. So go from 100% dose to a 66% dose to a 33% dose to off, and maybe as long a period as you were describing for adults, like 1 week steps. And if you don't have enough medicine, I think Dr. Yi was saying somebody doesn't have enough medicine and the hurricane is coming and stuff like that. If you don't have enough medicine, just taper with what you've got. Just take the number of doses and just make a line downward over 3 days, 6 days, something like that. And if we can gather these case reports that are known, that are previously described into some sort of publication, that'd be great. I want to mention 2 other things. So in previous parts of my career, I was a microcirculation blood rheology oxygen transport studier. And somewhere I just wanted to mention 2 ideas in there. One is that for oxygen delivery, it's not completely like all or none. It's more like irrigating and slopes and getting the water to flow down into the field. And to get to the farthest part of the field, you still need to have some slope to do it, but it may not take very much. So there's some concept that in the microcirculation, all you need to do is have some slope. And as long as there's a difference between the red cell and the tissue and the mitochondria, the oxygen can get there. And depends on the demand and how far it has to be from the blood vessels. So in addition to your medicine, it may be how sparsely populated your blood vessels are. And as many of you know, the blood vessels in people with sickle cell can drop out, and then you can have large gaps. But it's not the same for every person. So there's a heterogeneity that could be even different from having medicine there. that your host may have some susceptibility to ischemia or be able to tolerate it, or the oxygen binding. And oxygen binding is tighter to fetal hemoglobin than it is to hemoglobin A, so don't forget that part. And yet people with fetal hemoglobin are able to exercise and do other kinds of things. And then my other research hat was looking at oxidant stress. And so there's some idea that in malaria and sickle trait and resistance to malaria, the key thing was the oxidant stress imposed by having this unstable hemoglobin S there. And that was bad for the malaria parasite, good for the host. So what if you reduce the oxidant stress in this host by having Voxeletor there? Maybe that has unmasked the susceptibility to malaria that was there, protected because they were in a high state of oxidant stress. This is speculation, but it would be based on some sort of theory. So some of the questions are.
I'm gonna take some of them while you've been talking. I've been reading, so I think those are all such really good points. And again, a lot of this is speculation, but there is some things that we do understand in terms of how this medication works. So I see a really important question about someone who said we've run into challenges with pharmacy saying they can't legally dispense the drug to patients even for weaning purposes. And I've already put a few calls into Pfizer, as you might imagine, to respond to our request that we recommend weaning. We think it's the safest option because why wouldn't we think that? And so to make sure that this drug could be available in a very limited amount to wean patients. I've been told I'll get an answer from Pfizer today. So maybe by the 4 o'clock session, we'll know more. But I'm hoping that we'll be able to take care of that issue. I also see some questions about monitoring labs. Again, this is totally just me talking, not NASCC and no data, but I would monitor a CBC, a retic count, an LDH, and a CMP for those who want to know. Why are we doing that? We want to look at how much hemolysis there is, and we want to look at the kidneys and the liver as we do that. I also want to make it clear, because a couple of people have asked, that you need to call your doctor if you're taking this medicine. Call your hematologist. If you don't have one, I'm www.sicklecellcenters.org. Call the sickle cell center in your state. Message the Alliance. We will help you find a doctor. But we don't necessarily want individuals to just wean on their own, because we want you to be followed as you wean, with labs if you need it, with a doctor if you need it. So work with your physician. Again, the other thing that I have seen is questions about if you've been taking Voxeletor and haven't seen an increase in hemoglobin, do you still wean? We don't know the answer. My advice is, why not? Yes, go ahead and wean if you can, if you have the medicine, because maybe there is a benefit that we don't understand completely, even if your hemoglobin didn't change. And so it's still worth weaning. Dr. Sue?
Yes, and then there were a lot of questions about clinical trials. As far as I can tell, clinical trials are being halted also.
Right away.
So the opportunities to collect new data, quien sabe, I don't know what's going to happen with that. So a lot of what will be useful will be to use the information that's already been gained and try to publish it so that we can make the most of it. Now, there are obviously other medications still coming. Other medicines are in the pipeline as being tested. And then there's some medicines that are like derivatives or similar in mechanism to Voxeletor. Maybe the information we're gaining from this could provide some assistance too. There's a question that I don't completely know how to answer. How do we keep from losing patients' trust and faith? To me,
I do. I think there's lots of ways we answer that. I think we are here as a community, right?
Yep.
We are here to help. And I do believe, while I understand the amount of frustration and anger, right? Why did they suddenly pull this? Well, I want everybody to think that I'm hoping that they did this to keep people safe, that they did what they thought was most important and they put safety first. And that is what we always want, right? But at the same time, we also, again, know this is not a one size fits all disease. And so this doesn't mean this, and it doesn't mean this drug doesn't work for some people. And I've already started talking to the company about figuring out who this drug works for. But again, I do think it has to be in the hands of specialists. And I think that that's what we insist on. For people living with sickle cell, it has not ever been ethical that we don't have enough doctors to manage all of the individuals living with this disease. So let's insist on more doctors, more nurse practitioners, more PAs with this specialty. Let's insist on funding for this disease so that we can have the right amount of people that we need. Don't lose the faith. Use this as a reason to increase what we're doing, to increase how we do it together. And as these newer drugs come out, to make sure that we are ensuring safety in our patients and our warriors. Lewis?
Yeah, there's questions about how to wean, whether to wean, many. And so just to emphasize, this is suggestions, and it's if do it if you can kind of thing. One or two people are comparing this with hydroxyurea, completely different mechanisms of action, and hydroxyurea has had 30 years or almost, probably 30 years now, of safety record in lots and lots of people, including in sub-Saharan Africa, and it was found in 2 large studies to be actually helpful against malaria. So hydroxyurea, not to be tainted by this discussion, hydroxyurea, definitely keep it in a separate compartment. And if you're on hydroxyurea and you're not having problems with hydroxyurea, there's no reason to be worried about that. And there was somebody who suggested, if I'm on hydroxyurea and Voxeletor, should I stop both? No, I think—
Please don't stop both.
Yeah, because if anything, it's more important now to stay on the hydroxyurea, because that is the anti-sickling medicine you got. So just wanted to put in those suggestions.
And I totally agree with that. I think that when this medicine was started, the company compared how hemoglobin was changed by Voxeletor to act kind of like fetal hemoglobin. It is not the same. It is not the same for a number of different reasons. So this is not the same as increasing fetal hemoglobin. It's not the same as the way hydroxyurea works. We definitely don't want to raise fears where there aren't any, right? This is really important. This is specific to this medicine and specific to the way that it holds on to hemoglobin, and that it holds on to oxygen, that is different than fetal hemoglobin.
There was questions about whether this will be this presentation would be shared, and we're going to start with having a replay of this at 4 p.m. Central Time. 4 p.m. Central Time. The slide deck, I don't know if you want to share that.
Yes, we'll put it on our website as soon as we can, on the NASCC website, which for those who don't know is sicklecellcenters.org. And I've put it in the chat, in the Q&A too. And we will make sure through the channels that you got this information, that you get that too. And we will be on the Q&A as well to help answer, or I'll be on the Q&A as well. Lewis, I'm not speaking for you, at 4 o'clock to help answer other questions for people who couldn't attend. And we will talk about whether we can get the whole recording online.
And I'll also drop the registration link for the afternoon session in the chat for everybody.
Awesome.
Dr. Clark Brown is raising his hand, volunteering to speak.
I think we should wait and let's talk offline with all the different members of Pfizer is my suggestion.
Okay.
Because I've had other requests to speak and I don't know who to say yes to right this very second. The other question that I've heard a lot about, both in the chat, but also just in general, how do we communicate this? Really great question. My recommendation to physicians, physician assistants, NPs, call patients. Also send letters. And we have an example of that we're also going to make available to you online right away about different ways of communication and letters to send. But I always recommend a phone call whenever possible, as opposed to just sending a letter. And so I think that that is important. Another question that I wanted to make sure I answered, that I see two people asked, was this pulled only because of the study data? Was it only from the Hope Kids and the other leg ulcer study? And no, I can actually answer that. It was also from real world data, pharmacovigilance data, data from the Prospect, which is a long-term follow-up study. It was all of that together. So it wasn't just from the clinical trials. And I have heard that officially from Pfizer. And other people who said, can I take Indari? Absolutely. Doesn't reflect that medication. I understand for people who don't want to wean off on this drug. Right now, unfortunately, we don't have a choice. There is no other option right now. But we, Dr. Sue and I and others are working with Pfizer as fast as possible to get answers to some of these questions and to provide the best guidance that we have available. And again, we don't know for sure that the weaning recommendations that we're putting up there, maybe that's not 100% the very best thing, right? But I do think it's the optimal safest thing we can do. We're not going to do additional harm by weaning. It doesn't mean we're going to prevent all of the problems that could happen. We're just offering the very best advice that we have right now.
Yeah, I would not jump up and down and say you have to wean. I think it's just makes some sense, that kind of thing. And I do want to mention there are definitely some pattern that subpopulations of individuals with sickle cell benefit more from this than others. And there are some people where you don't have a whole lot of choice because they're not able to get transfused because of alloantibodies or because of renal failure or because of religious beliefs. And so for this subset, it's even more of a great need. And I think that trying to find the next medicines, the next things to do. But it does not seem like we can reverse the decision to withdraw this. Having additional discussions with Pfizer, but I have no power over a large multinational company.
And I think Derek Robinson has made a couple of really great points, as Derek often does. But I do want to make sure that people who maybe don't follow other drugs, right? We all live in our sickle cell world. This has happened in many other drugs. The best known is Vioxx, which was supposed to be an excellent, right, fantastic arthritis medicine, and they had to go back and take it off. So this hasn't just happened to people or to people with sickle cell disease. I think what makes sickle cell special and different is that it is a rare disease, so it doesn't affect that many people, and that it is so heterogeneous, right? Heterogeneous, meaning that not everyone is the same. And when we take a drug that has worked in a certain group and start giving it to others, there can be complications, which again is just why it is so, so important for us to be as careful as we can and making sure it's in the right hands. For those who've asked about compassionate use, I don't necessarily have the answers yet. I promise as soon as I know them, I will let everyone know, and I know Dr. Sue will too, and maybe there will be an option, but there isn't right this second. So very much right this second, we have to do what we have to do, which is to wean and stop it, but it doesn't mean that's a forever answer.
And part of the hope is that with transparency and discussion, that this is a new era of clinical research and of clinical practice, and trying to get everybody to not have misinformation, but to have the publicly available information spread as widely as possible, as fast as we can. I really don't want somebody to hear from their hairdresser's cousins, friends, neighbor about something, hoping that people can channel information to sickle cell groups, professional organizations, and that by networking like this, we can have leaders of community-based organizations, leaders of sickle cell centers, try to spread what we all know as one unified, or at least relatively unified message and not disparate types of things.
So we are at time. We are going to be back here at 4 o'clock. We're going to play a recording of the talk that I gave with the little data that we have with some recommendations. We'll be back for Q&A. This is the beginning of the conversation, right? This is not remotely the end, and we're going to get more data. And for those who asked if Pfizer will share data, I think that all of us will insist on that. And from what I have heard in talking to our pharma colleagues, as soon as they do their due diligence, they're going to work with us to know more. So I really believe we're going to get more information. And again, I do believe very much that we have a lot of hope. We have so many drugs coming, and that there are different drugs that are going to work for different people. So don't let this ruin your faith. We are going to get where we need to be in this disease. It's the best thing that we can do is work together to get there. So thanks everyone very much. Thanks to SCDAA for partnering with the National Alliance. And we really look forward to doing everything we can to support this community.
And suggestion to have community health workers also get on board with information. I can work on that too. Happy to work with my community health worker buddies.
All right. Thanks, everyone. Much, much appreciated for everybody getting up early. And we'll see you again this afternoon if you want to join later. Take care.